Hello, my name is Dr. Vij. I'm from My Cancer Haven. And today, in our Conversation with Cancer Experts series, we have a nationally recognized expert in leukemias, Dr. Nicholas Short, who's Associate Professor at MD Andersen Cancer Center, the leading cancer center in the United States. And he's going to talk about exciting new developments and how we incorporate non-chemotherapeutic approaches, Blincyto and Besponsa, into the frontline treatment of acute lymphoblastic leukemia. Welcome, Nicholas.
Thank you. Thank you for having me.
So, for our audience to put it in perspective, how are we doing today in terms of our outcomes for patients with acute lymphoblastic leukemia overall? And then we'll delve into the topic in greater detail.
So in many ways, some consider ALL to be a pediatric disease, and certainly it's more common in children. But certainly, I'm an adult leukemia doctor, and so I only treat adults with leukemia. So in the pediatric context, fortunately, this is a very curable leukemia for most patients. So you can see on the left side here, these are the survival curves over time. And, really now in most types of ALL, we have, long-term cure rates essentially over 95%. Now, historically, we've lagged behind in the adult population, but you can see here that we have made some steady progress. Obviously, outcomes were very dismal before the era of combination chemotherapy and better supportive care and a lot of the new agents we have now. And in the more modern era, in the last decade or so, we can now get in patients above 18 years of age, long-term survival rates close to 60%. And actually, I think in the last several years, with some of the new therapies that we have, we're improving upon that. And I would argue that with most contemporary regimens, we can probably get long-term survival rates closer to 80% in patients between 18 to 60 years of age with newly diagnosed ALL.
So as far as adult ALL goes, I guess the algorithm starts at, is it Philadelphia chromosome positive or negative? For the Philadelphia chromosome positive, historically, outcomes had not been great, and we used to do a lot of allogeneic transplants in eligible patients. But I think that a lot of work done by your institutions, among others, is trying to make that history. And so we're moving away from chemotherapy. So in this regard, I just wanted to discuss a couple of key trials. And could you tell us how your institution is slowly trying to incorporate non-chemotherapeutic approaches in this highly aggressive malignancy? And it's remarkable the success that you and your colleagues have had.
Yeah, so I mean, as you know, this is really a huge success in the treatment of leukemias and ALL specifically. Philadelphia chromosome positive ALL or Ph positive ALL was historically one of the most aggressive subtypes of all leukemias. Patients needed to, they got combination chemotherapy and had to go to transplant to have any chance of long-term survival. And even then, the outcomes were poor. And now we're actually treating patients with chemotherapy-free regimens. So this is data from the Italian group that ran the DiALBA study, which is evaluating dasatinib, so a second-generation BCR-ABL tyrosine kinase inhibitor, in combination with blinatumomab, so an immune therapy. So really a chemotherapy-free combination for patients, adult patients with newly diagnosed Philadelphia chromosome positive ALL. And with this regimen, they saw very deep levels of response. So you can see that, very high rates of molecular response. And this is translated to, long-term survival rates of around 80%. And this is really remarkable in the absence of chemotherapy. Now, one thing that's of note is that they still did transplant close to half of the patients in this study. So I think with this regimen, at least, it's still kind of an open question in terms of, do we need to consolidate these patients with transplant? But that said, just to get these results with the chemotherapy-free regimen is very impressive and shows the remarkable progress that's been made in this disease.
And I believe your colleagues at MD Andersen and yourself have taken this a step forward to include ponatinib instead of dasatinib. And can you just tell us a little bit about the experience here?
Yeah, so I mean, I think we believe that we can still hopefully improve upon the outcomes that we just showed in the previous slide. The rationale for using ponatinib is that this is a more potent BCR-ABL tyrosine kinase inhibitor. It specifically can target and is active against T315I mutations, which are really one of the main mechanisms of relapse in patients with Ph-positive ALL when they're treated with an earlier generation TKI like imatinib or dasatinib. And so that's really the rationale for us wanting to use ponatinib in this setting. So we give ponatinib initially at 30 milligrams, then we decrease it to 15 because ponatinib can have some cardiovascular toxicity. So we're trying to minimize the dose as much as possible. We give 5 cycles of blinatumomab in combination with it. The only chemotherapy per se is intrathecal chemotherapy, so via lumbar puncture, and this is still standard. Even when we talk about a chemo-free regimen, there still is this element of it, but there's no systemic chemotherapy. And then patients receive a maintenance of just the pill, just ponatinib for at least 5 years thereafter.
And what have you seen in terms of results?
So we're very excited about these results, again, with a chemotherapy-free regimen. We see very fast MRD negativity. So we know that MRD, or measurable residual disease, is a very important endpoint in all of our trials and in just treatment of leukemias. So we see that at least in the peripheral blood, half of the patients are already negative. We can't detect any disease by PCR for BCR-ABL. And this is translated, the very high rates of molecular response have translated to very encouraging survival. So you can see here, 2-year survival rate of 90%. So our follow-up is still a bit shorter than in the D'Alba study, but we're very encouraged by this. And I think one thing that's very important to note about this is that not only are we getting these very encouraging results, but we only transplanted 2 of the over 60 patients that we've treated so far. So we really believe that not only is this a very effective chemotherapy-free induction strategy, but also one that can overcome the historical need for transplant in these patients.
And it seems that this curve shows us that, led by your research over the decades, that the field is moving forward very impressively.
Yeah, so we, like I said, historically, you can see those bottom 2 curves, the outcomes were really poor. This was in the pre-TKI era. Then we had the introduction of imatinib and then later dasatinib. And, we thought we were making improvement by moving from imatinib to dasatinib, but when we look back at these data later, we see that unfortunately, we really didn't make much improvement with the addition of dasatinib. And I think this was really because dasatinib does not cover those T315I mutations. And so when we moved from hyper-CVAD, so chemotherapy, with dasatinib to ponatinib, we saw a really significant improvement in outcomes. And I think that's because of it's a more potent TKI and active against these mutations. And, the data are still relatively early, but we're hoping that we're entering a new era with these chemotherapy-free regimens, where hopefully we're improving outcomes even further, relying even less on transplant than we did before, without all the toxicity associated with chemotherapy.
So next, let's move to the larger bucket of patients, which is the Philadelphia chromosome negative bucket. And here too, your group has been instrumental in trying to incorporate these newer drugs, Blincyto, a bispecific to CD19, and Besponsa, antibody drug conjugate to CD22 in practice as well. So we'll review a series of landmark studies, some of which are complete, some of which are ongoing, to see how we are moving the needle forward here. So I guess I will leave it to you to walk us through how you at MD Andersen have been slowly but surely trying to remove the chemotherapy slowly and get these newer drugs into the frontline setting.
Yeah, so I'm happy to talk here about what we're doing at MD Andersen. So, the typical or historical hyper-CVAD regimen, which is very commonly used for patients with Philadelphia chromosome negative ALL, or really all types of ALL, was 8 cycles of intensive chemotherapy and then about 3 years of maintenance, so POMP maintenance for around 3 years. What we have done with these new drugs that we now have approved in relapsed refractory ALL, so blinatumomab, and then we'll talk in a bit about inotuzumab ozogamicin, is trying to incorporate those into the frontline setting so that we can reduce the need for chemotherapy. Just like earlier when we talked about blinaponatinib, we removed the chemotherapy entirely and replaced it with blina. So what we're doing here is now instead of 8 cycles of hyper-CVAD, it's 4 cycles. So we're trying to reduce the total amount of chemotherapy and the toxicity that comes with it. It's then followed by 4 cycles of blinatumomab. And then the maintenance phase is POMP, which is standard maintenance, alternating with blinatumomab. And rather than doing it for 3 years, we're now doing it for closer to a year and a half. So we're shortening the total duration of therapy as well. And so far, we've seen very encouraging data with this. And we've been doing the study for a long time, and we'll talk in a little bit, I'm sure, about how now blinatumomab is now really standard of care in this setting based on randomized data.
And you're also throwing inotuzumab in the mix.
Yes. So that what I just showed was a little bit was what we were doing until a couple years ago. And then now we've added inotuzumab because the idea is let's use all of our most effective drugs that we have, as long as we can combine them safely. Let's move them into the frontline setting to hopefully deepen responses, get higher rates of MRD negativity, less reliance on transplant, longer survival. So of course that's the rationale. So in addition to what I showed before, basically what we do now is low dose fractionated inotuzumab given in 2 of the chemotherapy cycles and 2 of the blinatumomab cycles. And we've showed some of these data so far, and the outcomes are really quite good. And it does look like adding the inotuzumab does seem to be better than with the blina. So we believe that hopefully in the future, patients will be receiving all of these effective drugs, the ino and blina, in the frontline setting as standard of care.
So I guess there are a number of groups working on the same kind of approach, and appears that initial results are very promising.
Yeah, so I mean, you can see across the board, all of these that are looking at the addition of blinatumomab show, whereas I showed you that other graph, and I said, the survival rates even up into 2020 or so was, maybe 60% in ALL. I think when we routinely incorporate blinatumomab, you can see that we pretty consistently get over 80%. The one exception to that is that last study, but that enrolled a little bit older patients, and that's probably why. The numbers are still very small with the second study on here, which is the one we just discussed, the hyper-CVAD with blina and ino added on. But we're very encouraged by 100% 1-year survival, and I will say with longer-term follow-up, that seems to be largely maintained. So clearly blinatumomab, is improving outcomes. And then the big question is, should we be using ino and blina? At my institution, we really firmly believe that, but we're trying to show it in the context of our ongoing clinical trial.
So next we'll talk briefly about a trial I think you hinted at that has made blinatumomab now mainline treatment based on actually randomized data. So could you tell us a little bit about this study design, and then we'll review the results?
Yeah, so this was a very important randomized study, practice changing in Philadelphia chromosome negative B-cell ALL. So this is the E1910 study, where patients. So we knew that prior to this study that blinatumomab is very effective at clearing up MRD, so measurable residual disease, and it was approved for that indication. But what was not known was whether or not we should be routinely adding it to patients in the frontline setting, regardless of their MRD status. So we talked about all those studies that are investigating that, but now we actually have randomized data that show the benefit of blinatumomab for patients regardless of MRD. So these are patients who received an initial chemotherapy. They were MRD negative, notably at a level of 0.01%, even though we do have better MRD tests than that, but that was the cutoff for this particular study. And then those MRD negative patients, where the standard of care has been just chemotherapy alone, were randomized to receive either chemotherapy consolidation or chemotherapy plus blinatumomab consolidation.
And what were the results?
So you can see here very dramatic improvement in overall survival, like very undeniable difference between those 2 arms. And it was not driven by any differences in characteristics. This was a randomized study, and no difference in consolidation with transplant, for example. Median overall survival is clearly obviously not reached. You see a long-term survival in the blina group over 80%, which is what we've seen in all those other studies. And unfortunately, and what we see is the historical we expect with chemotherapy, a long-term survival closer to 60%. So we've at least improved the survival from 60% to around 20% by introducing blinatumomab across the board, regardless of MRD status. And this is really now standard of care, and this is now approved by the FDA. So all patients with newly diagnosed B-cell ALL should be receiving blinatumomab in the frontline setting, whether it's because they're MRD positive after initial chemotherapy or just in general, because we know that even it benefits even patients who are MRD negative.
And I guess they further dissected the data based on the number of cycles. What were the salient messages here?
Yeah, so this is, I mean, this is a tough analysis. I don't think we really fully understand this yet, but I will say that we have seen, as you can see on the right side, that those patients who receive all 4 cycles of blinatumomab, which was the planned consolidation, did better than those who received only 1 to 2 cycles. Now, there are a lot of potential reasons for this. I mean, certainly some of them couldn't receive all 4 cycles because of toxicity. Some went off early for transplant. But I think the main message from this is that if at all possible, you should try to give patients at least 4 cycles of blinatumomab as consolidation, and those are the patients that have the best outcome. And you can see there, actually, the survival is closer to maybe 85% for those patients. So really, those are the patients who do the best.
Another area of research, and again led a lot by your institution, is how to treat ALL in the older patients that sometimes cannot tolerate the full intensity of chemotherapy that we've utilized to cure this malignancy. So in that regard, we'll just review some of the work being done there. So how are we doing in the older patients overall to set the stage for the discussion?
So I think it's, we show that there had been steady progress, definitely in the pediatric population and in the patients who are, between 18 to 60 years of age. You can see on the right side, these are data from MD Andersen. But historically, the best outcomes we could get in these patients was maybe a long-term survival around 20%. And as you mentioned, this is because these older patients, they do have a higher likelihood of having some poor risk cytogenetic and molecular features, but also they do not tolerate our standard chemotherapy well, particularly if you're talking about something like hyper-CVAD, which can be very toxic. So we didn't really make much in progress for many years. And then around 2010, we started integrating inotuzumab and then later blinatumomab into the frontline setting for those patients. And you can see the very dramatic improvement in outcomes that we saw in this last decade. And actually now we have long-term survival rates 40 to 50%, so more than double the historical expectation. So it shows that by reducing the chemotherapy and relying more on these novel monoclonal antibodies like blinatumomab and inotuzumab, we have made progress, at least more recently, in this older population.
So just reviewing a few of these studies, so what can you tell us about this study where it seems inotuzumab was followed by chemotherapy?
Yeah, so there's a number of studies, and we'll talk about a few of them, and that are looking at inotuzumab in the frontline setting in older patients. This is a study that used inotuzumab induction followed by maintenance chemo by I would say more like intermediate dose chemotherapy for this older population. Importantly, all of the patients responded, so that's very impressive. So there's a very high rate of response in the frontline setting, and we know inotuzumab, even in the relapsed refractory setting, gives an 80% response rate. So this is a very effective drug. And this translated to this older population, all of whom were over 55 years of age, to a 2-year overall survival of 80%. So, this is just another, proof of principle showing that integrating inotuzumab or blina, for that matter, into the frontline setting improves outcomes, and it allows you to use less chemotherapy than we were using prior to the advent of these antibodies.
So another study is the EVOL-INO phase 2 study. I understand this combined inotuzumab with low intensity therapy as well.
Yeah, I mean, this is very similar. So this is a similar population, 55 years of age and older. Induction is mostly with, vincristine steroids, inotuzumab, but then they start introducing some chemotherapy later on. So there is some chemotherapy into this. We see, again, 90% response rate, so very high, many patients achieving MRD negativity. Here, the 2-year overall survival is not quite as good. It's 54% or so. But that's still much better than the historical expectation. So we're still shows that we're making progress by bringing inotuzumab into the frontline setting along with some lower dose chemotherapy.
And then it seems like even with the a mini hyper-CVAD approach, you can combine INO and blina.
Yeah, so what we do at my institution at MD Anderson is we started with mini hyper CVD, so low dose chemotherapy with inotuzumab. Then later we also added blinatumomab. This is very similar to like I showed in the hyper CVAD in Oblina, where we do 4 cycles now of mini hyper CVD that along with inotuzumab, then 4 cycles of blinatumomab, and then maintenance with pomp alternating with blinatumomab. We see that all but one patient responded, so the overall response rate was 99%. MRD negativity at 10 to the minus fourth at least was 94%. And the overall survival, the long-term survival rate is around 50% in this population. So going from historically 5-year overall survival of 20% to 5-year overall survival of 50%. Now there still is some toxicity with chemotherapy, particularly in the patients over 70 years of age. And so we're interested in exploring chemotherapy-free approaches in those patients, so like inotuzumab and blinatumomab without any chemotherapy.
And so I guess the survival is looking better.
Yeah, so I mean, this is comparing to standard hyper CVAD, and this is dose adjusted hyper CVAD. So hyper CVAD adjusted for the patient's age, so lower doses, and you can see very clearly the improvement that's seen with this type of regimen compared to historical expectations. And we already showed that with the dramatic improvement that was made beginning around 2010, which was when we started using this regimen. So we're very encouraged by this general approach of using inotuzumab and or blinatumomab into the frontline setting, along with very minimal chemotherapy for patients over 60.
And it seems like others are trying to do away with the chemotherapy totally for the elderly.
Yeah, so we're doing a very similar study as well. So we have an arm in our study for patients who are 70 years of age and older that we give them INO and Blina. This is a study from the Alliance that looked at a very similar thing. So this is for patients over 60, the median age was 71 years, and they did induction with inotuzumab, and then that followed that up with blinatumomab. Just after the INO alone, the response rate was 85%. Overall, almost everyone, 97% of patients responded. We don't have very much follow-up data from this yet, but the 1-year overall survival is 84%. So we're encouraged by that. And I think the big question in the future is, do we need any chemotherapy for these older patients? This is at least one study evaluating that. We're looking at the same thing as well. We still do use some low-dose chemotherapy at my institution for patients who are between 60 to 69. But once they're over 70, this is the kind of approach that we use at MD Anderson.
And seems like with this kind of approach, we are making headway even in this older, more difficult to treat population.
Yeah, so I mean, I think you see a lot of different numbers here for survival. It kind of depends on how long the follow-up is, but I think that certainly we're seeing long-term survival, 5 years of at least 40 to 50%. We'll see with some of these other regimens if they're able to surpass that. But definitely very significant improvement compared to what we saw historically with chemotherapy only approaches. So really, I would say even though there's not an approval of inotuzumab, for example, in the frontline setting, I would say that at many academic institutions, many people are using inotuzumab in the frontline setting based on all of the data that's emerging, showing what looks like a benefit in these older patients.
I really want to thank you very much for reviewing this exhaustive set of studies. And obviously, we've come a long ways in acute lymphoblastic leukemia. Where do you see the field being in the next few years with all these studies? Where do you see we're headed?
Well, I mean, there's been a lot of changes in just the last several years. I think the general principle is that we're going to take all of our most effective drugs and use them in the frontline setting, because I think that is the place where we're best able to cure patients. So we've already seen that with Blina. So Blina now is on label for frontline consolidation. I think that we need the data, but I think that we will hopefully show that inotuzumab also improves survival using it safely in the frontline setting. One question is whether or not we should be consolidating patients with CAR T cells rather than transplant. I think that's another area of interest. We have studies ongoing that are just starting now using CAR T cell consolidation in the frontline setting rather than sending patients to transplant, because we haven't really seen transplant work very well in ALL. So I think that's what I'm excited about is, just hopefully continuing to improve that survival curve just with the available therapies we have. I think we just need to use them, move them into the frontline setting, use them properly in combination or in sequence, and I think that we'll be able to cure the vast majority of patients with ALL in the next several years.
It's remarkable how your institution has brought us to this point, coming from first developing the hyper-CVAD regimen to then incorporating these drugs into the hyper-CVAD backbone, and then moving away and seeing if you could just go forward with these drugs and maybe now CAR T-cell therapy, and leave behind the hyper-CVAD portion that you guys had initially brought to the world.
Yeah.
So I appreciate you taking the time to talk to us and educate our audience, and hopefully I can reach back out to you to review data from this exciting field and other areas of leukemia as it unfolds.
My pleasure. Thank you very much. It was my pleasure.
Thank you.